So if you've been to the channel before, welcome back. If you haven't, welcome. Today's talk is going to be on cervicoplasty, or more simply, neck lift. The aging neck is part of the complex of the aging body and aging face. It is rarely seen in isolation, but sometimes we see patients who have a neck which is saggier than you would expect. It also occurs rarely in younger patients and is predisposed in patients with a short chin, with a relatively short angle of their jaw, which means any amount of soft tissue hanging below the neck is more visible in these patients. Other contributing factors are skin quality, including sun and smoke damage, absolute age, and also your biological age, which is not always the same thing. Patients who've had previous face or neck lift surgery will obviously present with a slightly different combination of signs to those who've never experienced any surgical intervention. In simple summary, the changes we see in the aging neck include loss of skin elasticity, which is demonstrated by fine lining. We also see loss of elasticity of the underlying muscle. In the neck and face, the skin is very closely associated with a muscle called the platysma. The platysma essentially sits like a hammock underneath the chin, supporting the soft tissues of the neck. But as we get older, this particular muscular hammock either gets weaker or becomes a little stringy. We call these platysmal bands, and they're also part of the aging neck. Other tissues involved in aging of the neck are the hyoid bone. Hyoid is a bone at the root of the neck, and it actually defines the cervicomental angle. This is the angle between the submental jawline area and the neck itself, and is often a sign of a well-defined neck. As we get older, not only does the platysma and skin sag forward, but also the hyoid slips a little forward and lower, which can make that angle more oblique, and is often something that patients present with. Some patients simply have a low or poorly angled cervicomental angle, and they complain that they would like this to be improved with some type of surgery. Other tissues that contribute to the sagging or aging neck include the submandibular glands. These are two relatively large salivary glands, the size of a large grape, sitting either side of the midline. These can hang through a slightly weak platysma and contributing to a loss of submental definition. One other tissue type to bear in mind is fat. Everybody carries fat in different places in their body. The submental area is no exception, and in fact some young patients carry fatty tissue in their submental area preferentially over other areas of their body. We often see these young people presenting for consideration of definition of their neck. In the older patient, weight gain can be deposited in this area, again causing a heaviness, which also results in the sagging of the muscle and skin overlying. Resultant from all of these tissue changes, we see that the neck descends forward and down, which loses definition of the cervicomental angle or the chiseled jawline. Also, the face descends across the jawline, creating jowls. Jowls are actually part of our facelift discussion and not represented by this particular talk, but it's important to know that jowls are a result of a sagging face rather than a sagging neck specifically. So in an attempt to reverse some of these changes, we address our surgery, removing some of the tissues that can be removed, tightening as many tissues as can be tightened, and also tightening in separate stages the skin and the muscle in order to create the most robust tightening that we can. The first technique of neck lift or cervicoplasty that we will discuss is a similar technique to that used during a facelift. The incisions are behind the ear, although they do tend to come just up and in front of the earlobe, but they are not the same incisions in front of the ear into the hairline that we see with a facelift. Through this incision, we perform submental liposuction, trying to remove as much, if not all, of the fat that we can between the platysma and the skin layer. This is of significant value, and even in slim patients we see 5 or 6 cc's of fat. In larger patients we can see up to 25 or 30 cc's. Unfortunately, the only fat that we can target with this liposuction is the fat between the muscle and the skin. This is not always the entire story, and there is usually some deeper fat. This fat unfortunately surrounds the thyroid, the carotid artery, the jugular vein, and a number of important nerves in the neck, which are unsafe to target during a cosmetic procedure. Through the incision behind the ear, once liposuction is complete, we then ensure that the platysma muscle is completely dissected away from the skin. This allows us to tighten the platysma muscle and skin completely separately, allowing the two to move independently of each other. The key advantage here is that we can then encourage the two layers to stick back together in a mutually tightened state. Once both are as tight as they can be, then this tends to allow a lamination process where the two layers stick together with a thin layer of scar tissue. This scar tissue causes a much stronger, stiffer platysma skin complex, which should prevent early recurrence of a sagging neck. In my practice, we do not use drains. What I do use is sutures, which aim to cause multiple points of adhesion of the skin and the platysma muscle. If we can encourage early adhesion of these two layers, then we minimize the opportunity for swelling and hematoma, which unfortunately are well recognized complications of neck surgery. After surgery, and once the quilting stitches have been placed, a facelift dressing will be applied. This is a slightly tight band of soft dressings which loop from under the chin to the crown of the head. This will stay for 12 to 24 hours and then be removed. A take-home Velcro version of this facial binder is given to patients, and they are encouraged to wear it for 2 to 4 weeks following their surgery. The other approach to neck tightening or cervicoplasty is through a medial approach. This involves a small, typically 2 centimeter long scar under the chin, typically at this point here, halfway between the chin and the hyoid bone or the root of the neck. Through this incision, we once again perform submental liposuction. The key advantage of this incision is that it allows us to tighten the platysma muscle in the midline instead of pulling it up behind the ears. A second advantage is through access through the platysma muscle, we can also tighten the digastric muscles. These run from the hyoid to the tip of the chin, and in tightening them we can raise and reposition the hyoid. We also remove any fat from between the digastric muscles, and suturing the digastric muscles together in a digastric corset and then repairing the platysma muscle over the top of this creates a very flat surface under the chin itself. The skin is then closed. Quilting stitches are utilized to create as much tightness as is possible. This second technique can be further reinforced by combining it with the first technique, creating not only tightening upwards and backwards of the peripheral platysma muscle, but also tightening downwards and inwards of the midline platysma muscle. This is a classic extended neck lift and forms a significant part of my practice, and is the best way to create as much tightening of the submental tissues as is possible with plastic surgery. Some surgeons augment this entire technique with removal of some or all of the submandibular glands. Personally, I have considered this but choose not to do it. I have almost never seen a neck which has had this surgery look noticeably worse because of heavy submandibular glands, and operating on the submandibular glands creates a risk of bleeding. Complications of any of this type of surgery: every patient undergoes some swelling, bruising, and asymmetry and lumpiness. This is likely to last for 2 to 3 weeks, but at least if the surgery is confined to the neck, then it typically heads down and can be covered. The swelling occasionally, but only rarely, heads up across the jawline onto the face. Infection is rare, but unfortunately does occur. In my experience, infection complicates maybe 1 in 30 to 1 in 40 of these cases. Unfortunately, it can lead to additional stiffness and a prolonged period of recovery. If we choose to make an incision under the chin, as we described, then this incision tends to be the slowest to heal of all the scars that we make on the face. It is at the most dependent part of the operation, namely the lowest point, and the swelling and bruising that gather around this incision and tend to make it quite stiff and a little lumpy for 3 to 6 months. Sometimes we need to revise this incision to make it neater, but it is very rarely a cause of significant concern as long as the patient fully accepts that in order to make the neck as tight as we can, this additional incision is chosen. A very rare complication of neck lift surgery or cervicoplasty is an injury to the marginal mandibular nerve. This is a nerve that runs from below the ear, along the neck, and then across the jawline, and it supports the corner of the mouth, preventing some degree of sagging. This nerve sits under the platysma and can be bruised but is very rarely injured. But if the patient demonstrates some weakness of this particular nerve, then careful observation over many weeks or months may be necessary, waiting for the nerve to spontaneously recover, which in the vast majority of cases it does. It's important to state, however, that there is no guarantee that the nerve will recover, but injury to this nerve is a very rare eventuality. 2 more things to mention. Neck lift or cervicoplasty is quite rarely done on its own, but is much more commonly associated with a facelift. Many patients demonstrate a similar degree of aging to their face as they do in their neck, but some patients associate a facelift with a certain stigma. I often tell people that if you are considering having your neck lifted, this will create a third of the overall improvement, but will be 2/3 of the surgery and typically slightly more than 2/3 of the cost. For the vast majority, a lower face and neck lift, including one or both of these techniques, is the preferred option, both for the patient in terms of rejuvenating their entire lower face, but also in terms of cost benefit. One final point to make is in patients with very heavy necks, or in sometimes male patients who can grow a beard to cover the scar, there is an alternative to a cervicoplasty neck lift as we have described. A simple vertical excision of the excess skin under the chin, creating a scar that runs from the tip of the chin all the way to the root of the neck, can be performed. A relatively wide amount of skin and platysma muscle can be removed in this way, creating quite a significant improvement in neck contour. Closure of this particular incision needs to adopt a Z-plasty or Z shape in order to prevent tightening of the scar and webbing of the neck. The patient will be left with a Z-shaped scar running from the tip of the chin to the root of the neck, which their beard can often grow through, hiding it in the early instances. This operation has a high level of satisfaction, accepting that the scar is not invisible, although will fade over time. The bristles of the beard can often create some irritation to this scar, and it can take 6 to 12 months to settle in total. And as I say, it is typically a technique preferred by male patients. I've never performed a submental Z-plasty neck tightening in a female because of the scar being slightly more obvious. If you have any questions about neck tightening and would like me to answer them, then please get in touch with me at adamgoodwinsurgery.com or via the contact details at the end of this video. If you have any comments or suggestions for this video or any subsequent videos, please let me know. And if you enjoy the content, then feel free to like and subscribe.